I call this lecture Double Jeopardy, Critical Illness and Pregnancy. I know it's a mixed crowd, but I think everyone will get some pearls from this lecture, at least I hope so. So let's jump right into it. I do have a financial disclosure. I do lecture for a pharmaceutical company called CSL Behring, which is actually located not far from here in King of Prussia. And the therapy that I speak about is Kcentra, which is a PCC, which is used to reverse warfarin-induced hemorrhage. That's the last you'll hear about PCCs in this lecture. I have no other financial disclosures. We're not talking about PCCs today. We're talking about mom and baby and critical illness, and I take care of a lot of critically ill patients, so this is going to be sort of from my angle, but again, I think you'll get some pearls to take back out of this lecture. So how many of you get anxious or nervous if you have a ill or critically ill pregnant patient? I would expect more hands. Mine's going up. Sort of the goal of this lecture from me to you is to decrease that angst, to decrease that nervousness. I think if we have some pearls on diagnostics and critical illness, a way to treat these patients, an algorithmic approach, that'll take away from some of that anxiety. So that's my goal. And a lot of that anxiety comes from having two patients that are ill, mother and baby, or fetus, right? So it just the stakes just got higher. It went from one patient to two patients. Here's my objectives. There's a lot of information here. I chose these things to cover today. We'll go over some basic normal physiology of pregnancy. We need to know normal before we recognize abnormal. And then we'll touch on a few keys to resuscitation, and then a little bit about airway management, the approach to pulmonary embolus in pregnancy, peripartum cardiomyopathy, how do you diagnose and manage that, preeclampsia, eclampsia, we'll move through that pretty quickly, and then go through cardiac arrest and trauma in the pregnant patient. And the majority of these illnesses, when I'm focused on, I'm going to be patients in second, third trimester of pregnancy. I'm not really focusing on first trimester and things like ectopic pregnancy. So, normal physiology. We have to recognize this, and this is not a board lecture, so we're not going to cover all of the physiologic changes in pregnancy, but we will cover some of them that I think are pertinent. So, cardiac changes. I think the easiest way to remember this in our pregnant patients is mostly everything goes up except blood pressure. Blood pressure goes down, right? Most pregnant patients are running normal blood pressure or maybe a little bit low, but everything else goes up. What am I talking about? Heart rate, stroke volume, circulating volume. So we need to recognize that, especially in critical illness. It may mask it or make it difficult to diagnose. Pulmonary, some changes. The FRC goes down, the PCO2 goes down, tidal volume, minute ventilation, respiratory rate all go up. And so this comes to play a little bit when we're thinking about, for instance, pulmonary embolism, because patients with pulmonary embolism get tachypnic. Well, pregnant patients often run a little tachypnic, and this comes into play when we're managing airway because the FRC goes down, and these patients become much more difficult to pre-oxygenate when we manage their airways. We'll come back to that. Probably the biggest change is the enlarging uterus. As the baby grows, fetus grows, uterus enlarges, it moves organs out of the way in the abdominal cavity. Lots of changes. The biggest change we have to know about is compression, especially in critical illness, is compression of the venous system, aorocaval compression, the inferior vena cava. With the enlarging uterus, the vena cava can get compressed, particularly as the patient advances in pregnancy, and that can cause hypotension and reduced perfusion, right? So one of the big take-homes you're going to see, or keys to resuscitation, is if you have a critically ill pregnant patient, no matter what, if they're hypotensive or not hypotensive, tilt. Take the pressure of the uterus off of the vena cava. Either push the uterus to the left or tilt the patient to the left. It doesn't matter if they're hypotensive. That maneuver alone will probably improve perfusion. And these are actually my keys to resuscitation. This is earth-shattering information here at AROC today. I'm going to blow you away with this. These are my keys. If you can remember this, it will reduce your anxiety in taking care of these patients, and you will take better care of these patients. Number one, mom first, eye to baby. Mom first, eye to baby. Mom first, eye to fetus. Whatever you want to call it, just give me credit because I came up with it. Take care of the patient, which is the mother first. It doesn't mean we ignore the fetus. It just means I think resuscitations go bad with critically ill pregnant patients because we're focusing too much on the fetus. Because fetal outcomes are dependent on maternal outcomes. So forget about the fetus initially, and I'll show you how to do that, and take care of the mother. Mom first, I to baby. You know you're going to have to do things for the fetus. Just keep those in the back of your mind, but resuscitate the mother the way you know how to resuscitate the mother or any other patient as if they weren't pregnant. Number 2, I already told you, tilt. Take the uterus off of the vena cava. It doesn't matter if they're hypotensive or not. It'll improve perfusion. Number 3, give them oxygen IV fluid. Earth-shattering, right? It's amazing what we can do with these simple concepts that we've learned from when we trained. Let's talk a little bit about airway management. You can spend an hour on each of these subtopics: airway, PE, peripartum crown. So I'm just going to hit some pearls. Pregnant patients are by definition a difficult airway. Our colleague in anesthesiology could tell us this for a variety of reasons that are listed here. They're relatively obese, difficult to bag, higher Mallampati's at baseline, risk of vomiting, aspiration. When we try to do rapid sequence intubation on these patients when they're ill, they desaturate very quickly because of the physiology of pregnancy. So pre-oxygenation is tough, and it becomes key in managing their airways. We have to pre-oxygenate them properly. And then progesterone. We have to respect progesterone. So one of the things that progesterone does as far as the airway is it makes tissue more friable. And so when we go to manage an airway, we put a blade in a mouth and touch that friable tissue, and they're more prone to bleed, which makes that airway more difficult. So we have to recognize this ahead of time and take measures to maybe decrease that bleeding. So for all of these reasons, difficult pre-oxygenation, progesterone, and everything else listed here, pregnant airways are difficult. Now the patient's critically ill, it becomes more difficult. So what do? Here's my pearls. Prep. Prep harder than you've ever prepped, if you can, for the airway. Use a concept that we call no desat. They're hard to pre-oxygenate. So how do you pre-oxygenate them? Put a non-rebreather on them, and then put a nasal cannula on them. And when they're apneic during what we do, which is RSI, when they're critically ill, keep the nasal cannula on them during that apneic period, and they still get oxygen flowing in, even when they're not breathing. That's the no desat concept. Pre-oxygenate them sitting up. It's much easier to oxygenate patients sitting up prior to intubation. Have an algorithm, which means if your standard intubation doesn't work, what's your next step? You should always have that actually in mind, but particularly in a difficult airway. Video laryngoscopy, we use this a lot now. It's made difficult airways much easier. Okay, it's a very good tool. There's not a lot of literature on video laryngoscopy in the intubation of pregnant patients, but I'll tell you, based on the fact that they bleed a lot when you intubate them due to progesterone, I find video laryngoscopy to be a lot gentler than direct laryngoscopy. So for me, I think it's a good move. Okay, you can use less force to visualize the airway. In preeclamptic, eclamptic patients, they often have upper airway edema. They just don't have edema in their legs, they have edema in their airway. So be ready with equipment such as smaller endotracheal tubes to pass through the vocal cords. And I think some of these things will help you manage these airways much more effectively. Typically, all the medications we use for rapid sequence intubation, and some of them are listed here, are safe. As far as we know, because there's not a lot of literature, they're safe. I'm talking about etomidate, I'm talking about ketamine, I'm talking about succinylcholine, rocuronium. About the only one that's not safe that we stay away from is what? Benzodiazepines. All right? So we'll stay away from those when we pre-medicate and paralyze these patients, but everything else is pretty safe. And after you manage their airway, our sedatives are safe, things like propofol, etc., as far as we know, with the exception of benzodiazepines. Vent settings, based on ideal body weight, and just go with what you typically go with, and use end-tidal capnography. Pulmonary embolism. We think about this a lot in pregnant patients. Here's the numbers. It's a fairly common cause of maternal mortality, and it's difficult. It's difficult for you, and it's difficult when they come into me in the emergency department, and it's difficult for a variety of reasons, and here's some of them. I think we often either overestimate the risk of pulmonary embolism in these patients, or we underestimate it. And I'll explain that concept in a second. Also, a lot of the symptoms of pulmonary embolism overlap with the symptoms of normal pregnancy, right? Tachycardia, tachypnea, edema of the lower extremities. So we can write it off. That's normal pregnancy, right? So that's called underestimate the risk. Overestimate is by trimester, and I might as well just explain it now. The risk for pulmonary embolism or venous thromboembolism in pregnancy goes up by trimester. And it's the highest in the third trimester, peripartum, and postpartum period. You all know this. The first trimester patient is actually fairly low risk. They're about the same risk as a patient who's not pregnant, to be quite honest with you. But I think we overestimate it in the early trimesters. It's really much more of a risk in second, especially third trimester. And then it's also difficult because we don't want to test these patients. We don't want to give them radiation, CAT scans, VQ scans, et cetera. So we don't. So how do you approach the patient who has signs and symptoms of pulmonary embolism who's pregnant? Use your gut. We all have it. I think it works pretty well. It's been shown to work well in the literature. Or use a clinical decision rule. There's some out there. The only problem with the clinical decision rules, like Wells criteria, et cetera, they haven't been studied in pregnant patients. So you're applying it outside of what they've been studying. But I think that's okay, because they're pretty good rules. What's the patient's true risk? Okay? Are they third try, second try, first try? Because remember, first try is not that high risk, to be quite honest with you. There's a rule called PERC, which deems patients low risk for pulmonary embolism. You can find it on MD Calc. It's really not been studied in pregnant patients, but I think it's a pretty good rule, and I tend to look at it. And you can adjust the heart rate in the PERC rule to 105. And then what's the role of D-dimers? Because we use D-dimers in low-risk patients to exclude the disease, and we know in pregnancy, because of physiology, the D-dimers can be up, right? So there's some data, although it's not great data, that you can adjust D-dimers in pregnancy. So adjust the negative cutoff range in pregnancy. And so at our shop, the negative cutoff's 0.5. Let's say it's 500. Okay, 500 to make it safe. I just shifted the decimal point. First trimester cutoff, 750. Second trimester cutoff, 1,000. Third trimester cutoff, 1,250. Adjust the D-dimer. I'm not saying it's good data. I'm just saying there's some data to support that that may be okay to use. So you can consider adjusting it. This is my algorithm. I created this. And so this is how I think you should approach pulmonary embolism in pregnancy. And some of this is in line with guidelines, and some of it is outside of what the guidelines tell us to do. And I'll tell you, the guidelines have no evidence. Okay, so pick what you want. You can pick this or you can go with the guideline. But there's no evidence among any of those guidelines, ATS, OBGYN, there's no evidence in pregnant patients. And so here's what I think you should do. You see the patient, decide if you're going to work them up. Use your gut. Is this patient so low risk that there's no way they have a pulmonary embolism? Or am I worried? And if you make the decision to work the patient up, you have to be able to go all the way down to the bottom of the algorithm, which is imaging. So you've made that decision in your mind, I'm going to work this patient up. They're high enough risk that I just can't send them home or discharge them or bring them back the next day. So I'm going to work them up. Consider using the dimer. You don't even have to age adjust it if you don't believe me. If it's negative, you're done. Right? It's pretty darn sensitive. If you have a high sensitivity dimer and it's negative, I think you're done. Okay? If it's positive, you're moving on. I think the next thing you should do, and these are in stable patients, fairly stable, all right, get an ultrasound of the lower extremities. Now, some will say, don't do that. If they have no symptoms in their lower extremities, why would you even get a Doppler? The yield is so low, and I agree. I actually agree. But if the Doppler is positive and the patient has symptoms of pulmonary embolism, you could be done and just treat the patient if you wanted to. All right? So consider that if you have the resources and the time and the patient is stable enough to go over and get Dopplers. If the ultrasound's positive, you can treat the patient. If the ultrasound is negative, we're coming down this way, then you're going to imaging. I think the next thing you should do is a chest x-ray. And the reason to do a chest x-ray is, number one, you may pick up an alternative diagnosis, like a pneumothorax or a pneumonia or something else. And number two, it guides the rest of your imaging. Because if the chest x-ray is normal, then a VQ scan is a viable option. If the chest x-ray is abnormal, probably your best test is a CT angio. And I say that because if your chest x-ray is abnormal, in any sense, atelectasis, etc., that decreases the yield on your VQ scan. That increases the chance that your VQ scan will be indeterminate. Does that make sense? So I use the chest x-ray, and I might pick up an alternative diagnosis, but kind of try to guide me. And I'll tell you, probably the best bang for your buck is going to be a CT angio overall. But this gives you some options. So again, make the decision. You've made the decision. Proceed down. Dimer negative, done. Dimer positive, consider Doppler. Doppler negative, you continue down. You're going to get a chest x-ray to help you branch off. And since I've started using this, I have no angst in working up pregnant patients for pulmonary embolism. I know where I'm going every single time. Radiation, we're always worried about radiation. And we have terrible data on this, but the data that we have extrapolated from bombs is probably 50 millisieverts is a safe threshold for fetus. For fetus, probably 50 millisieverts is safe, and you can see the estimated fetal radiation doses from CT and VQ listed here. And you can see that they're way less than 50 millisieverts. Now, no one's ever put a Geiger counter by the fetus and scanned the mom and measured the amount of radiation that the fetus was getting. So all of this is extrapolated and extrapolated some more. But my point is the imaging studies are fairly safe when it comes to radiation, as far as we know. I don't know if there's any radiologists in the room, but there is something called the all or none phenomenon, which you have to be aware of. And so there is a thought that at the right time in very early pregnancy, if fetus gets a zap of radiation, that may cause a miscarriage, and that's called the all or none. So at that right point, very, very early, if you get the right amount of radiation at the right location. But outside the all or none phenomenon, it's pretty safe. And you can see VQ has more radiation to fetus than CT scan. You can see those numbers right here. Now, CT scan has way more radiation to mom, and so that's a concern, so we have to consider that. So again, if your chest x-ray is normal, pick your poison, VQ or CT. But I think if the chest x-ray is abnormal, go ahead and just get your CT scan. And as far as we know, bottom line is contrast is safe to the fetus. Peripartum cardiomyopathy. I just find this disease fascinating. And so it was described in 1880 by Virchow. This is the same Virchow that described the triad for venous thromboembolism. Same dude, all right? In 1937, it was described a little bit better, and then they changed the name. It went from postpartum to peripartum cardiomyopathy, and the reason is how it's defined. So it's defined as heart failure within the last month of pregnancy or 5 months postpartum. Hence, it's not just postpartum, it's peripartum. Makes sense. It's most common postpartum, and the definition is heart failure in the absence of another etiology, in the absence of heart disease, in this population of patients. Okay, so they don't have CAD, they don't have valvular disease, they don't have a viral myocarditis, etc. You've excluded everything else, and they have CHF, by definition, a systolic function or an ejection fraction of less than 45%. So that's how you define it. Risk factors very similar to preeclampsia, eclampsia. They're listed here. All right, we'll move through this slide. The only one that's not similar to preeclampsia, eclampsia is prolonged use of tocolytics. Those patients on tocolytics for a prolonged period of time are at risk for peripartum cardiomyopathy. Here's my pearls for this. You just have to suspect the disease. You have a critically ill pregnant patient comes in, chest pain, shortness of breath. Think about that this could be the etiology, and then exclude the more common things. So pretty sure it's not a PE, and be pretty sure it's not preeclampsia, because those things are way more common and they present in a similar fashion. And then if you're left it's not those things, continue on, think hard. BNP will be up. EKG probably won't help you make the diagnosis, but the BNP will be up. So you'll have a clinical suspicion, you'll have a positive BNP most of the time, and then an echo will help confirm that. The gold standard is MRI or biopsy. You're not doing that, right? You're not doing that. You're going to have a clinical suspicion, you're going to exclude other things, get the echo, and make your diagnosis. And the treatment is very similar to an exacerbation of CHF. Now, mind you, these patients present along a spectrum of disease. They can be pretty darn stable, and they can present in shock and dying, anywhere along that spectrum. So they don't have to present a specific way. It can be any of those ways. And so you would treat them how they present. If they're critically ill, in shock, obviously the treatment's different than if they're stable. But it's a lot of the same treatments as for CHF, and you can see them listed here. It's primarily supportive loop diuretics, ACE inhibitors if they're postpartum, but if they're pregnant, no ACE inhibitors, obviously. Nitro beta blockers, pressors, they're all safe. So how you would treat that acute CHF, minus ACE inhibitors if they're pregnant. And for fetus, here's some things to think about. Again, avoid ACE. Be cautious with higher doses of loop diuretics because they can cause oligohydramnios, so monitor patients for that. And these patients should get cardiotocographic monitoring for the mom and the fetus. Remember, prep hard, pre-oxygenate those patients sitting up, use the no DSAT. All the meds are safe as far as we know, minus benzos. And post-tube management, use end-tidal capnography. For PE, I say have a diagnostic algorithm in mind. Patients either very low risk and you're not working them up, or they're at risk and you're going to start, and I gave you an algorithm that you can approach those patients with. And then peripartum cardiomyopathy, I think rule out PE and preeclampsia first, however you want to rule them out, clinically or with testing. Keep them in the back of your mind. And if you make this diagnosis, manage it similar to CHF with supportive care, loop diuretics, etc. Very quickly, because I think this will run long if we go through this in detail, Preeclampsia, eclampsia, we see this, you see it, it's pretty common. The risk factors are here. This is after 20 weeks of gestation. And the classic, what I want to bang home right now is the classic criteria for preeclampsia are up here. Elevated blood pressure, hypertension, proteinuria, edema. And that's what we've all learned. And actually, the majority of patients do have that. But these are not really the diagnostic criteria for preeclampsia. These are minus those. Okay? You don't need proteinuria, although most patients have it. You don't need it. And you don't need edema, and edema is actually gone. So although they're common, you don't need those to make the diagnosis. What you need is elevated blood pressure plus end organ damage. So mild, we would say, is systolic over 140, diastolic over 90. Severe, we would say, is systolic over 160, diastolic over 110. And it can be any one of those numbers. Systolic or diastolic up would give you the diagnosis plus one of these. So some renal involvement, cardiopulmonary involvement, low platelets, high liver enzymes, severe headaches, or hyperuricemia. This is how I think you should think about preeclampsia, not hypertension, proteinuria, edema. I think you should think of it as end organ damage, as a hypertensive emergency. Hypertension plus end organ damage. I think that's the criteria for preeclampsia. And so some of these actually delve into the HELP syndrome, right? Low platelets, high LFTs. And HELP syndrome is a little distinct from preeclampsia. 10 to 20% of patients who have HELP do develop preeclampsia. So they're a little distinct, but HELP is, you can have a partial HELP or a complete HELP. You can have all three or two of the three. But just remember these as your criteria. And remember, it's your systolic up or your diastolic up, plus end organ damage. Eclampsia. Eclampsia I want you to think about as a grand mal seizure past 20 weeks. That's it. Eclampsia equals grand mal seizure past 20 weeks. You don't actually even need to have hypertension. In fact, most of them do, but you don't need to. And a lot of patients actually present with the seizure and then have the hypertension after that. So excluding patients who have a seizure disorder or an underlying cause for a seizure, eclampsia is that. Without any underlying cause or a seizure disorder, it's a grand mal seizure past 20 weeks. That is eclampsia. That's it. Most of them do have elevated blood pressure. It's not required. And realize this, about a quarter of your mild preeclampsias, a quarter of them will progress to eclampsia, which means that we should treat them. A quarter of them will progress right to eclampsia and not even become severe preeclampsia. So how do you treat them? This is sort of basic, but let's just cover it. So mild preeclampsia, get the blood work. We talked about some of the labs that might be useful, uric acid, platelets, LFTs. You classify them as mild based on their blood pressure. Just realize they can be eclamptic pretty quickly. So monitor their blood pressure. You don't have to treat their blood pressure, but you should give them magnesium. 4 to 6 grams bolus, 1 to 2 grams per hour drip. And then expectant management versus delivery per OBGYN. And they'll make that call. Consult. And we give MAG to prevent progression to eclampsia. That's why we give it. It also decreases the incidence of placental abruption, but that's why we're giving it. For severe eclampsia, preeclampsia, or eclampsia, these patients are obviously coming in. You may end up adding a blood pressure agent because their blood pressures tend to be higher. The treatment is the same. It's magnesium, bolus versus followed by drip. You'll need benzos as needed for seizure control, okay, for an acute seizure, but it's really magnesium first. And I actually just CT all of these patients' heads because if a pregnant patient comes in and they seize, I don't know how to tell that there's not blood in their head. I just have no idea how to differentiate that clinically. I can't see in their brain. And so they're all going up to L&D. The majority of them are getting delivered, and they're getting their head spun on the way to make sure they don't have an intracranial hemorrhage, because that's different than eclampsia, and that has different treatment parameters. Trauma, one of the leading causes of maternal mortality, non-obstetric related, 5 to 8%. Again, I think if there's ever a struggle in a critically ill pregnant patient, it's these next two. It's trauma and it's cardiac arrest. It's always a struggle. There's so much stress. There's 2 patients. It becomes even more evident because there's more people around in the room managing these patients. And so the struggle is real when you have a 2nd, 3rd trimester trauma patient who's pregnant. Here's some of the risk factors. And I'll let you read those. And a lot of them make sense. And I'll point to this one. domestic violence, because we don't really think about it probably as much as we should when these patients come in as traumas. Was it an assault? Does the story match up? Okay. Most common is MVAs, because we see those all the time, but think about domestic violence and some of these risk factors. So I'm going to flip the way I talk to you guys about this, because I said mom first, I to baby, but we're going to talk about baby first here. Some of the fetal considerations in a pregnant trauma patient. And so one of the big ones is fetal maternal hemorrhage or mixing, right? And so the take home here is if there's trauma, you have to consider mixing. You're talking about in Rh negative patients or mothers. So in the Rh negative population, if there's trauma at all, whether it's minor or major, you have to entertain that there could have been mixing and therefore treat. And the treatment would be ROGAM. And so we're taught there's a low dose and a high dose, and I would just say give the high dose, okay? And the reason I say that is you can't tell how much mixing there is, and there may be ongoing bleeding or mixing, and you're trying to prevent something like fetal anemia or high drops. And so if you want to make it simple, if you have a pregnant trauma patient and they're Rh negative, you're going to give them ROGAM. And the ROGAM dose is going to be 300 mics. Now, the other thing is we're told to give it within 72 hours, and I agree with that. But I have myths. You guys have myth written there? I think, yeah, myth. And the reason I say that I think that's a myth is, yes, ideally you would treat these patients within 72 hours, but you can't tell me that if you had someone 5 days post-trauma and they came in and they were Rh negative that you wouldn't give them ROGAM, and that there couldn't possibly be ongoing bleeding, and there may not be a benefit. And so I would say treat people outside that window. Ideally, yes, within 72 hours, but certainly consider treatment outside that window. And the other take-home here is it happens with minor trauma, commonly. So the minorest of traumas. I'm talking about sprained ankles. I'm talking about banging against a table. Consider those as well. The KB prep, we tend to do these on our larger traumas. We're looking for fetal red blood cells in the maternal circulation. It picks up higher levels of mixing. Remember, even less than a cc of mixing can lead to alloimmunization, but this will pick up about 5 fetal RBCs in the maternal circulation, so a bit more. And so I would say consider doing this, but you're still going to treat the patient even if this is negative, right? But you may consider doing the KB prep, in your larger traumas, to maybe assess for redosing ROGAM, to assess for continued bleeding and mixing. And I would say the biggest reason to probably do it is there's a link between a positive KB prep and preterm labor in your trauma patients. So those patients who have positive KB prep have a higher incidence of preterm labor. So maybe a marker if that's going to happen. And then fetal considerations will still on it, obviously monitoring. So pregnant trauma patient, past 20 weeks or 24 weeks viability, okay? Past viability should be monitored. And you're monitoring for signs and symptoms of placental abruption, signs and symptoms of preterm labor, and so cardiotocographic monitoring. So whether the trauma is minor or major, these patients should get cardiotocographic monitoring. So this is what we talked about in the trauma patient. Remember, we reversed it. It is mom first, I to the baby. But we talked about the fetal considerations in trauma. Number 1, fetal maternal mixing, okay? Rh negative mom, give ROGAM. Give 300 mics, ideally within 72 hours. Number 2, cardiotocographic monitoring, okay? For a minimum of 4 hours, but if there's an abnormal tracing or monitoring, you're going to prolong that, and you're looking for signs and symptoms of abruption and preterm labor. And probably you're going to end up doing a pelvic exam to look for any signs of ruptured membrane. So those are your fetal considerations. But the approach is mom first, okay? So basically, you're going to approach the patient, the mother, as you would any other trauma patient, which is what we typically do is ATLS, A, B, C, D, E, so airway. So we already talked about airway. Consider the airway could be difficult. Breathing, assess breathing. If these patients need tube thoracostomy, you're probably going to go up a little bit higher for tube thoracostomy than your typical landmarks because of the uterus pushing up on the diaphragm. Circulation, remember aortocaval compression. So if you're going to put lines in these patients, put lines above the diaphragm because the thought is lines below the diaphragm won't be as effective due to aortocaval compression. Remember to always displace the uterus to improve perfusion. So, okay, you can't really turn your trauma patients on the left because they're on a backboard, but you can push the uterus to the left. So have somebody manually displace the uterus, and if they need blood, it's going to be O negative. Expose the patient, look for all injury, and then we often do a fast exam in the emergency department looking for fluid in the belly for solid organ injury. And so I would say extend your fast exam and look at the fetus as well. Look for signs of movement and cardiac activity. So pearls here for trauma patient. Remember, mom first, eye to the baby. Try to determine the gestational age early. Ultrasound can help you. Take a look at the fetus. Even in mild trauma, consider that there can be fetal-maternal mixing. Always consider giving RhoGAM in Rh-negative patients. Get OB involved early, and always think about domestic violence. We're going to end with cardiac arrest after. This is our quick summary of preeclampsia, eclampsia. So remember, I told you about the diagnostic criteria for preeclampsia. You don't need proteinuria, and you don't need edema. You need hypertension, end organ damage, suspect it, and the treatment is magnesium to prevent a progression to eclampsia. And remember, in the trauma patients, it's mom first, eye to baby, with your fetal considerations. We'll wrap up with cardiac arrest. Not common. Don't see it very often. It's challenging. It's stressful. There's not a lot of literature on this. So here's some pearls. Mom first. Okay, now this one, you got to keep a little closer eye on baby. All right, and I'll tell you why in a second. So mom first. CPR's the same. CPR is the center of what we do for cardiac arrest. Your hand position will probably change, especially if the patient has advanced pregnancy and the uterus is pushing up on the diaphragm and the uterus is very enlarged. So probably you'll move your hand position up, and it's recommended about 2 centimeters higher on the sternum. So change your hand position for CPR. You pretty quickly want to try to determine the gestational age of the baby, okay, or the fetus. Because if the fetus is of a viable age, you may consider doing a perimortem C-section, which we're going to talk about, or OB may consider doing perimortem. So you want to quickly determine that. So how can you do that? Well, if the uterus is at the level of the umbilicus, it's about 20 weeks, and that may be close enough to viability there. So uterus at the level of the umbilicus or above, consider possible viability. It's the same. If it's a shockable rhythm and it's cardiac arrest, you will shock it. The defib doses are the same. Pad placement is the same. Medication doses are the same. As far as we know, they're safe. The only thing is if there's internal, external fetal monitors, the recommendations, those should come off. How you do that, I don't know. Quickly, I have no idea. But for defibbing patients, the recommendation is to remove those monitors prior to defib. Lines above the diaphragm, drug doses, I said, are the same. If the patient's on magnesium, you're going to stop the magnesium and give them calcium, because that may be the reason for their cardiac arrest is the magnesium drip. So this is for patients in L&D usually. And remember to tilt, right? To increase perfusion, someone should be taking that uterus pressure off of the vena cava. So always tilt or displace, however you can do it, whatever's easy. It might be hard to do CPR and do this. So my thought is pull the uterus off the vena cava. Here are some of the things that can cause cardiac arrest in the pregnant patient besides the normal bleeding, embolism, whether it's coronary, pulmonary, or amniotic fluid, uterine atony, preeclampsia, eclampsia, cardiac disease, abruption previa, sepsis, the list goes on. Here's some things to think about. And we'll wrap up talking about perimortem C-sections. And so these are a rare occurrence. And the reason to do this, and I would say this happens extremely rarely, and if you make the decision, you go through with it, is you may improve the outcome of not only the mother, but the fetus. So by taking the fetus out during a cardiac arrest, you improve maternal perfusion, right? So taking fetus out, fetus steals blood from mom, mom steals blood from fetus, so fetus comes out, it'll be mutually beneficial. The thing to remember is this is a very poor prognosis procedure. The majority of these don't do well. So I'm not advocating to do these routinely, but I'm advocating to think about it. So cardiac arrest, moms of fetuses of viable age, you need to determine that early. And if that's the case, you can consider doing this to save mom's life and fetus's life. Now, what we're taught in emergency medicine for this life-saving heroic procedure is to try to do it within 5 minutes of maternal arrest. Because if you do it outside of 5 minutes, the prognosis is very, very poor for the fetus. The fetus won't live, or they will not live unless on a ventilator. So to do this very, very quickly. So what we're taught I was taught when I was a resident is to do CPR for 4 minutes and do ACLS for 4 minutes. And if it's not working, then to do the perimortem C-section. So you give yourself a minute to do the procedure. So you're within that 5-minute window that would be potentially get a good outcome. I would say think about doing it earlier, okay? Think about doing it way earlier because a minute doesn't seem long enough to me. So if you have mom that goes into cardiac arrest and you happen to be in that scenario, think about it early. Don't wait. Start your CPR, start your meds, start thinking about underlying cause, get your gestational age, and think about doing it earlier. I'll also say this whole 5-minute thing comes from case reports. There's no literature on this. It's just case report after case report. And here are some of the case reports. So I dove into this. So a couple of them here, and this one looked at almost 100 cases, 95 cases of cardiac arrest in a mom where perimortem C-sections were done. And what they found was the prognosis was poor, which I already told you, but there was actually okay survival for fetus and mom out to 10 minutes. That there was as good survival at 10 minutes as there was at 5 minutes in these case reports. And so what I'm telling you is that in certain circumstances, you may even consider extending that window, that every patient is different, that every patient doesn't live by one rule that we're taught in medicine. So the rule we're taught is 5 minutes, but maybe some patients maybe get a benefit out to 10 minutes. So consider it, I think, out to there. What this did show us was out to 20 minutes, no survival. So that's way too long, okay? So I would say start thinking about this early. The earlier the better in the right circumstance. Overall, the prognosis is going to be poor, but you may be able to extend that window in doing a perimortem C-section. And I'll refer you to the site, mcrit.org. They have a nice video of how to do this with limited supplies. What they tell you is to continue CPR, know the indication, viable fetus within 5 to 10 minutes, have some mental fortitude to do this, because it's going to take some guts to do this, and you're basically going to make an incision from the umbilicus all the way down the symphysis pubis, down through the uterus and taking the baby out. It's a quick procedure. It's not a time-consuming procedure. My summary. Remember maternal physiology? We talked about cardiac, lungs. My keys to resuscitation is mom first, eye to the baby. Always tilt the uterus off of the vena cava to improve perfusion. Airways will be difficult for a variety of reasons, so you have to prepare for that. Things like bleeding. Okay. Consider using video laryngoscopy. Pulmonary embolus, stratify your patients properly, and then proceed down a diagnostic algorithm to make this diagnosis. Peripartum cardiomyopathy, always think about PE and preeclampsia first. This is a diagnosis of exclusion. Your echo and your clinical presentation will help you and treat them with supportive care. Preeclampsia, eclampsia, we have to recognize this. The diagnostic criteria, I think, that we're taught are old, and treat these patients with magnesium. A quarter of them of preeclampsia will progress to eclampsia. Trauma, mom first, eye to baby. Remember, monitor fetus, fetal-maternal mixing, and then cardiac arrest. Most of what we do for non-pregnant patients applies to pregnant patients, meds, doses of defibrillation, et cetera, and consider a perimortem C-section. I think I have a couple minutes. I'll take any questions, and I'll leave with this. The slides that you have are a little older. I updated these just a bit, okay, just a bit. So if you want the updated slides, if you want any of the references, just shoot me an email and give me a couple days. I'll shoot you references, slides, whatever you need. Thanks for your time.